How's everyone doing tonight?
Good, thank you.
All good, if a bit smoky up here.
Where are you at?
Up in Humboldt, near the Trinity County line.
You have some
Southern,
fires going on up there?
yeah, we've had a couple days of thunderstorms in the afternoon and evening.
And that caused some fires?
Oh yeah,
Hmm.
lots of little ones and a couple big ones, none close to me, thankfully.
Well, that's good to hear. We'll get started in about 10 minutes. Jose, are you there?
Yeah, I'm here.
Can you monitor the chat?
Sure.
I also made you co-host.
Good. No Chin tonight?
He's at the mechanic.
He's what?
At the mechanic.
Oh, okay. Hey, Patrick, you guys getting the Sunday stuff together?
The Sunday stuff?
Yeah.
What
There's
Sunday
some
stuff?
kind, there's some kind of pop-up going up. Chin sent out.
A pop-up drill?
I don't know what it is. He wanted facilitators for this Sunday.
Oh, we canceled it.
Oh, you did? Okay.
Yeah, I didn't know that he actually sent out that email.
Well, it's nice to know that you canceled it.
He was CC'd on that email.
Huh.
The Point Furman team didn't think they could get enough their people involved that quickly. So they asked to cancel it or postpone it, but I don't know if we'll be able to do it in September either.
Okay.
You said Point Furman?
Point Furman,
Yeah,
Coastal Stampede drill. What was that, Bob? You're breaking up.
There's going to be a pop. This is Bob.
You
I'll
were
mute you.
all broken up, Bob.
Anyway, I never got a message that they were going to have a pop. So,
Yeah, I was trying to coordinate
well.
with the team down there to get the wigwam, but unfortunately they decided to cancel it.
Okay. I'll
Good. I can
Shouldn't
sleep
be
in Sunday.
available, and I didn't have any confirmed facilitators, so it was just easier.
You're gonna have me.
Oh, well, if I had known, would have split you
No,
into people.
I told Chin. Okay.
Jen didn't tell me anything. All right, we'll get started in about 2 minutes. Good evening, everyone. My name is Patrick Botts Forbes. I am the LAFD CERT Central Bureau Coordinator, and I'd like to thank everyone for attending tonight. Tonight's topic will be on neighborhood incident response teams. We do these continuing education trainings monthly with advanced topics, intermediate topics, and beginning topics. We try and bring in topics of interest, topics that extend the CERT program beyond the basic training and expand your capabilities and skills. One of the most important things we talk about are the incident response teams, and this is actually exactly what the CERT program was designed for. After a disaster, the most critical thing that we can do is help our neighbors, and the incident response team is the core of that response. One of the most important things we can do as CERT trained members or members of our community, members of our neighborhood, is help our neighbors really deal with the small emergencies that they might encounter. If we're talking about an earthquake, we're talking about a tornado, a hurricane, hail, winter storms, anything that overwhelms the abilities of the professional responders. Um, so much that so when you call 911, the expectation that we normally have, which will be that we're going to get emergency response within a few minutes, and they start saying it's going to be hours before you're going to get response. Um, if you have a minor emergency, you might not be able to wait those few minutes, or I'm sorry, those few hours. But what you really need is help, and it might be exceeding your ability, especially if you're injured. And so, what the neighborhood disaster response teams will do is really help help their neighbors prevent these small emergencies from becoming life-threatening disasters. Neighborhood disaster response teams are really going to do whatever is needed of them. They're going to respond into their own neighborhoods, into their own communities, and organize and find out what's going on. And then, as you and your neighbors find out, hey, we need to do this, or this is what's needed of us, this is what people need, this is where they're having emergencies, this is the injuries that they're seeing, these are the power lines that are down, these are the car crashes or accidents that normally the professionals are going to be able to respond to, but they're not able to now. You are going to operate within your own skill set, within your own training, and within the equipment that you have to really help your neighbors out. And this is going to include doing an initial damage assessment, find out how bad it is out there. But for the most part, you're going to be doing basic first aid. If we think about an earthquake or tornado or a hurricane, what you really are able to do at the basic level is basic first aid. It doesn't require that you be an EMT or emergency medical responder, but just even being able to bandage up a wound, um, apply some triple antibiotic to something, keep it clean and dry is going to help that injury from getting infected. There are going to be certain dangerous hazards that you're going to be able to tape off and keep people away from that will prevent them from getting injured by that hazard. You're going to be able to do some cleaning and clearing to make sure that you're mitigating some of the things that have come down. If there's glass or debris that is dangerous that people could fall on, trip on, getting that out of the way is going to help immensely. And then even doing basic traffic control. Maybe there's something in the road. Maybe there's a flooded street and there happens to be a sinkhole that is flooded, and people could drive into that and actually submerge their vehicle, or worse, get stuck and drown. You being able to divert traffic around there, keep people from entering that unsafe area, is gonna save people's lives. And throughout the process, until really the professionals come in, till you have outside responders reporting and able to take over the situation, you're going to be continuously triaging and reassessing the neighborhood, because what happens right at the beginning isn't the only disasters that are going to occur. You're going to have maybe aftershocks, or you're going to have things that were not a damage or a hazard that will suddenly become a hazard. Maybe something is in the process of falling over, but it hasn't fallen over yet. And as things get worse over time, it does eventually fall and become a hazard. So things will have to be constantly reevaluated and reassessed. Most important thing that we can do really is we can be a visible, calming, reassuring presence within the neighborhood. What I envision CERT is, the Community Emergency Response Team, is our green vests and helmets are really our uniform. And if people know what we're doing, know who we are, know that we're trained, then they know that help is there. And it doesn't require that you have to have turnouts and flashing lights or anything. You just being there to help people answer questions, be there to hold people's hands because they're panicking and they've never been through this kind of disaster before. You're actually able to calm people down and reassure them. And that in and of itself is going to be a massive asset to your neighborhood. I don't have the updated statistics on this, but in 2019, 83% of LAFD 911 calls were medical related. If you think about this, this is thousands of calls a day. That's a lot of medical calls. During a disaster, say an earthquake, these calls aren't going to go away. They're going to increase. Yes, we're not going to be fighting fires. We're not going to be putting out burning homes. We might put out a small brush fire. I'm sorry, a small, very small fire, prevent it from getting worse. But if something is fully engulfed, we're not going to be dealing with that kind of issue. That's what the fire department's going to be doing. But if someone steps on broken glass, we can certainly help clean the injury and bandage it, dress it, make sure it doesn't get worse. Most injuries actually occur after an earthquake during sorry, let me try that again. Most injuries that occur during an earthquake occur during the first few minutes after the earthquake, and then about an hour later, because people are cleaning up, and that's when they get injured. One of the biggest injury that we saw during Northridge was cut up feet. And that's because most people, they're not wearing shoes in their homes. They're walking around barefoot in socks or slippers. And if you think about the number of things that are hanging on your shelves, on the walls, picture frames, things with glass on it, those are going to come off the walls. Those are going to land on the ground broken. And really, if you're trying to get to your kid or your children and they're screaming for help, you're not going to stop to see if it's safe to walk on that. And so you're really, most of these injuries are going to be just the basics, just really cut up feet. And what we can do in the first few hours of making sure that people's injuries are tended to will prevent them from having to go to the hospital. What our biggest fear really is that these small injuries are going to become infected. And that's why it's so critical to just have basic first aid training, know how to clean a wound, know how to bandage it, make sure that it doesn't get worse. We talk about team sizes, and the numbers here are very specific. Even numbers can be broken up. And so when I talk about a team size being an odd number, 3, 5, or 7, it's really intentional to avoid breaking up that team. That's one of the things that we want to make sure we avoid, is having a team of 4 go out and suddenly you have 2 pairs that can be easily split. And so the smallest element of a team is going to be an odd 3-person team. And that's going to consist of a team leader, a radio operator, or a radio communicator, and a scribe. And that's going to be our damage assessment team, or the core leadership element of a incident response team. In addition to that, we add on the incident response teams, pairs, responder pairs. And this brings that up to 5 or 7. So, and of course, with ICS, Incident Command System, we keep track of span of control. We don't want to have a team of 15 out there that report to one team leader, because that team leader is not going to be able to adequately keep track of that number of people. You want to make sure that you don't overwhelm any one person, any one team leader. So the team sizes are very deliberate in terms of the number, 3, 5, or 7. For this slide, I got some feedback on it, and the feedback came from a chief. She felt that I should order this by importance. And my response was, I did. I actually feel that the scribe is the most important person on the team. A scribe is going to be documenting everything. And as the teams go out, as the teams go into hours number 4, 5, and 6, you're going to be referring back to their documentation constantly. And if you don't have good documentation, you don't have a good scribe really tracking what's going on, it makes team operations very difficult. So I actually consider the scribe the most important person on the team. Second to that is the radio communicator. This person is going to be communicating back with staging and making sure that staging knows where you are, that you're getting direction from staging on where you need to go next, and if anything happens to you, that you can get help to where you are. The team leader is, I don't want to say the least important person on the team, but really, if everyone is doing their job, the team leader is not the most important person. Everyone who's doing work is the most important person on the team. The team leader's job is really to keep everyone safe and make sure that everyone gets home safely. This person needs to be hands-off, and this person really, this team leader, is setting the tone for the team. If they're calm, if they're providing guidance and good leadership in terms of confidence and direction, then it's not that they're not the most important person on the team, but the team will operate without them getting in the way, if that makes sense. This I've seen time and time again, where a team leader wants to be hands-on. They want to be the most important person. They think they have the greatest number of skills. They might be an EMT. They want to show off. They want to be, they want to feed their ego. And this leads to problems with the team really not functioning as efficiently as it should. The team leader really needs to be hands-off. If you think about it, if you're hands-on, you're paying attention to what's going on directly in front of you, you're working on a patient, you're not paying attention to the rest of the team. You're not paying attention to what's going on around you. You're not making sure everyone is safe. You're developing tunnel vision as you're focusing on what's directly in front of you. And at that point, you fail to be the leader. You become the hands-on responder, and someone else needs to step up and become the team leader. And I've seen this time and time again, where the team leader jumps in and goes directly onto the patient, and another team walks up and is asking what's going on, and the team leader is focused here instead of seeing that another team is approaching and saying, hey, this is where we need you, this is how we need to support the situation. A team leader doesn't need to be medically trained, but I find that an EMT as a team leader is actually a great resource, because you as an EMT or medically trained person can help multiple people at once as a team leader by directing your hands-on responders. You can give guidance and you can support multiple people. If you're a hands-on responder, you're working on one person. So no, a team leader doesn't need to be medically trained, but it is very helpful. But that's up to you. If you want to be the hands-on, you want to get bloody, you want to get your hands dirty, then don't step up to be the team leader. Be a hands-on responder and get your hands dirty that way. A team leader is going to set the energy and tone of the team. If you have a team leader who's nervous or anxious, jittery, they're not confident, they are worried, they are they just don't exude that leadership that you expect out of them, it's going to set the entire team back by that. The entire team will become nervous or jittery. They won't have confidence in their leader. And yes, again, the team leader is not the most important person, but they set that tone. And so you really want someone who you can count on to keep you safe and make sure the team is going to get the job done, and that someone you feel confident following, even if the team leader is not the one that's going to be doing everything. And again, if you do have a confident, calm team leader, the entire team is going to feel that energy and they're going to feel much better following that person. The team leader's job, again, is really essentially to make sure the team makes it home safely. If you as a team leader get your team home safe, you've accomplished job number one. The worst thing that can happen to is somebody gets injured on your team, and now you have to recall the entire team, or you need to get someone else out there to help your team member because they did something unsafe, or something happened to them, and now that entire team can't complete the mission. One of the other things the team leader is going to be doing is really working with staging to find out what needs to be done, to share information back from the team. The team is boots on the ground. The team sees what's going on out in the world. While staging is blind, staging is also seeing the big picture. As an incident response team, you're seeing what's going on in the field right around where you're at, but you might not see what's going on down the road where another team is seeing something. And so it's a two-way street. You as the team leader need to convey to staging what is happening in the field, but trust that staging is also making sure that you need to be where your team is most valuable and able to do the most amount of good. It's very important as the team leader and as team members to get to know each other and establish the roles and expectations from step zero. Before you even leave staging, get to know everybody's name. When you talk to people, address them by their name. If your team builds that rapport, your team is going to be able to really gel and mesh better than if everyone's just referring to each other as, hey, you, or you with the backpack, or you with the, hey, you're an EMT, right? Or you with the radio, come here. The other thing you want to do is confirm directions. When somebody says something, it's good protocol to repeat back the direction, because if you've ever played the game telephone, you hear something and you might be distracted, or there might be other noises out there. So maybe somebody has an accent. And if you just assume that what you heard was correct, then you're really risking getting that direction wrong, that piece of information wrong. So always repeat back. And yes, it adds time and it does add repetition and it does add redundancy, but that is important because you want to make sure that you know that you heard that piece of information correctly. One thing that we see sometimes, especially when tensions get high and stressful and there's a lot going on, is that people tend to kind of lose their cool. Yelling happens, and that is not a good thing. When you're talking to members of your team, especially if you're the team leader, you want to keep a calm, even tone and pace, because again, as the team leader, you're setting the tone for the rest of the team. If you're yelling at everyone, that entire team is going to be anxious. They're going to be nervous. They're going to be jittery, or they're going to be really uptight because they're getting yelled at by their team leader. And so that team is not going to function as optimally as it should. But if you as a team leader or you as team members are talking back and forth and just kind of keeping a cap on it, and yes, maybe you have to repeat yourself a few times, and you're not, I personally hate repeating myself over and over again. It starts to make me anxious. But if you can control that, everything is going to flow better. The radio communicator's job is, quite frankly, to communicate. I see this time and time again when we have teams out there, the radio communicator is waiting to be told what to do, what to say on the radio. As a radio communicator, your job is to share information with staging proactively. As you approach the incident that you're dispatched to, let staging know. Staging, this is Echo Team. We're on scene at incident number 5. We're at the intersection of Walk and Don't Walk. Staging, this is Echo Team. We're at incident number 5. This is what we have here. You're providing your location, letting staging know that if you take a turn, if you haven't updated them recently, if there's a piece of situational awareness that they should know, because again, staging's blind. They don't know what's going on out there. You tell them that there's trees down. That's good information for them, because chances are, even if there's no injuries or damage from the tree falling, but there's multiple trees that are down, chances are one of these trees will have fallen on somebody and injured them. So just let them know stuff and proactively. As the incident goes on, your team is working on it. Update staging periodically. Let them know how things are going. You don't want to let staging know with no communication, hey, staging, we're done. You haven't heard from us in the last 30 minutes, but all of a sudden we're done. Let them know, hey, staging, this is Echo Team, incident number 5. We're wrapping up now. We'll probably be free of this incident in the next 5 minutes. That lets staging know that they're able to start planning your next incident and where they need to send you next. And again, you really don't want to wait for your team leader to tell you what to tell staging. It's your job as the communicator to talk to staging. And part of that process is getting good radio communication and protocols in place. What we talk about are the 5 W's. If you format your radio communication in this manner, you're going to have strong radio communication, regardless of your experience level. Who are you trying to reach? Who are you? Where are you? What do you have? And what do you need? Who are you trying to reach? Staging. Who are you? Echo Team, or whatever team your name is. Where are you? At corner of Walk and Don't Walk. Staging, this is Echo Team. We're at the corner of Walk and Don't Walk. What do you have? What do you need? We have 5 survivors, 3 immediate, 2 delayed. We need a second incident response team, or we need transportation to the hospital. Putting that all together, it's going to sound something like this. Staging, this is Echo Team. We're at incident number 5 at the corner of Walk and Don't Walk. Staging is going to confirm. Echo Team, go ahead. Staging, this is Echo Team. At incident number 5, we have 5 survivors, 3 immediate, 2 delayed. We need transportation to the hospital. Simple. If staging needs to know more information, they'll ask for it. Chances are they're going to want to know the nature of the immediates so that they know the priority of how quickly they need to get these people to the hospital. The scribe is always an interesting part, an interesting role. A lot of people don't want to be the scribe because they think it's not an important role. And as I mentioned earlier, I think it's actually the most important role. The scribe needs to be active. They need to be documenting what's going on, but they need to be asking questions. They need to find out what's going on so they can document it, because when communication has to happen, when the radio communicator needs to call staging, that scribe is going to hold a lot of the information they're going to need to share with staging. Or when you need to go back in your notes and say, hey, what happened at this time? What was the flow of the incident? That scribe is going to have all this information. I actually like to talk, our Valley Bureau coordinator came up with this idea that the scribe is kind of the deputy. The scribe knows everything, and the deputy is able to take over for the team leader, because the scribe knows what's going on. And if something happens to the team leader, it's really the scribe that should be stepping up next. So if you want to think about it, if you're interested in being in a leadership role, start looking at being a scribe. You're documenting what's going on. You're keeping track of who, what, where, why, and when. And that flow of information is critical to having a smooth incident run. You're going to be documenting things like location. When staging calls, sends you to a location, you're going to be documenting it, because, hey, where did staging say we're going? If we didn't write it down, we might not have that information correct. Was that, some of us might be dyslexic. Was that 5231 or was it 2351? How many survivors are we expecting? What did staging say? Or when we get there, we have 5 survivors, but staging said that we only had 3, or they said there were 7. So where's the discrepancy here? Because what the information we're seeing and what we got when we were deployed, did we lose somebody? Are we at the right incident? Is something else going on? But also when you go back to staging and we need to document, okay, where were these people transported? Who did we have here? Somebody's looking for somebody. This is the information that the scribe is going to have. When you're documenting, you might say that we have 5 survivors, 3 immediate, a 35-year-old female, 20-year-old male, 15-year-old female, 2 delayed, 40-year-old male, 5-year-old female. You can abbreviate. Every scribe is going to document differently. One thing you do want to document for sure are the immediates. So in the notes that we have here, if you look at it, the 35-year-old female, 20-year-old male, and 15-year-old female are immediates. The 40-year-old male and the 5-year-old female are delayed. We care about them a little bit less than the immediates. When we triage, the immediates are the people who are going to die within the next hour if they don't get medical attention. The delayeds may or may not die without medical attention. They certainly need to be attended to, but we really care about those immediates. And so you want to document the nature of the injuries for the immediates. 35-year-old female, rapid breathing. That when you do triage is considered immediate. 20-year-old male, unconscious, definitely immediate. We don't know why they're unconscious, but they shouldn't be unconscious. And the 15-year-old female has a severe upper thigh laceration with the tourniquet. That's important to know, because that person, even with the tourniquet on, needs to go to the hospital. That person's probably going to go into shock. And so the sooner you get them to the hospital, the better. I like to say that the scribe and the radio communicator are the first pair of responders. They should be side by side, really working together. As a radio communicator, if you have a good scribe with you, that scribe can give you what you need to say over the radio in bullet point form. Remember, we're talking about the 5 W's. If you have a good scribe, they're anticipating your message to staging. They can write down the 5 W's for you, and you just read it off their notes. Staging, echo team, corner of walk and don't walk, incident number 5. We have 5 immediates. We have 5 survivors, 3 immediates, 2 delayed. Immediate number 1, 35-year-old female, rapid breathing. Immediate number 2, 20-year-old male, unconscious. Immediate number 3, 15-year-old female, severe upper thigh laceration, tourniquet has been applied. All you have to do is read off these bullet points, and that's good radio communication right then and there. When we're making up the rest of the incident response team, we're adding on to the 3 core members, 3 leadership roles, that team leader, radio communicator, and scribe, with hands-on responders. And if you're not a team leader, not a radio operator, and not a scribe, you're a hands-on responder. These are the people who are going to be doing the work. These are the people who are going to get their hands dirty. These are the people who are going to be saving lives. If you're a hands-on responder and you're coming up on someone, say it's a medical, you have an injury, someone who's injured, you're going to make primary contact with the survivor. You're going to introduce yourself. You're going to assess them. You're going to treat them. If you're the hands-off responder, you're going to be handing supplies to the hands-on responder. You're going to be taking notes. You're possibly going to be communicating on the radio. I like having, especially for medical, hands-on, hands-off responders, because during drills, we've had moulage in the supply kit. That means somebody who had their hands bloodied, fake blood, of course, contaminated the sterile supplies that were in the bag. That's not good. So having that pair set up where you have a hands-on and hands-off responder, with the hands-off responder getting the supplies, it's going to make things go much smoother. Now,
Patrick,
yeah.
got a question.
Mhm.
From, where are we? Kimberly Williams. What's the difference between an immediate and a delayed person?
Immediate is someone who's going to die in the next hour without immediate medical attention. A delayed is someone who may or may not die, but they need medical attention. Does that clear that up?
I think so.
That's a lot of people. I know we talk about having a team of 7, and especially in the state of, well, not everybody knows what CERT is. Most people don't know what CERT is. Most people have never heard about the Community Emergency Response Team. Most neighborhoods don't have teams. Most neighborhoods, most teams, if you're lucky, if you have 10 people. So saying that you're going to have an incident response team of 7, that's a lot of people. That's an ideal. It's an aspiration. If we can do things properly, we can get people trained up. This is how things should go. Then we know what to strive for. But there's a couple golden rules here. And golden rule number 1 is do the greatest good for the greatest number of people in the shortest amount of time. And that really, as we talk about what CERT does and how we respond into the neighborhood, this golden rule is our guideline. When you're encountering an incident, if you always fall back to do the greatest good for the greatest number in the shortest amount of time, that gives you the direction of how this incident should happen. If you're doing a damage assessment and you encounter someone and they need help and you don't want to leave them, do the greatest good for the greatest number in the shortest amount of time. Helping one person over helping multiple people who you don't even know need help, it gives you a little bit of guidance. Do we want to get stuck here with one person? Do we do CPR on someone who is not breathing when we have a mass victim incident, when we have a disaster, when we have an earthquake and we find someone, the first person we encounter, they're not breathing? Well, if you start doing CPR on someone, you can't leave them. You can't stop doing CPR. Once you start, you can't stop. So you don't do CPR during a disaster because you can't help other people. And so that guidance is really the direction that the community emergency response team follows. Rule number two is do what you can with the resources you have. If you have 5 people on your team, you have 5 people on your team. If you have 3 people on your team, you have 3 people on your team. Yes, we talk about 3, 5, and 7. We talk about a radio operator, a scribe, and a team leader. If you're the only one there, you're the only one there. Do what you can with the resources you have. But if you do have more resources, that's where we start talking about where we want to go with things. And then we train to that. Let's train up more people. Let's get more people involved. Let's do drills. Let's get people practicing the ideals. And then if things don't go right, things start off slower than we'd like, we know where we need to go with things, but do what you can with the resources you have. In terms of medical, I mean, pandemics, right? Body substance isolation is important to make sure that we stay safe from the people we're trying to help. And it's called standard precautions. If you're medically trained, you learn about wearing medical gloves. They should be non-latex because some people have latex allergies. Some people who wear latex gloves can develop latex allergies. So non-latex gloves are ideal. But if all you have are latex gloves and you're not allergic to them, that's what you have. Do what you can with the resources you have. When we talk about N95 masks, especially because of COVID, we talk about the medical ones versus the construction ones. In general, the construction ones are good when there's dust in the air. That's great. But when you're talking about a medical incident, the idea of the surgical mask, procedural mask, or the N95 mask is to prevent you from actually contaminating or infecting your patient with whatever you have, not so much the other way around. The gloves definitely keep their stuff away from you. So if they're bleeding all over the place and you possibly have cuts on your hands, the gloves are going to reduce the chance of you getting infected by them. But the surgical mask is to prevent you from breathing onto their open wounds. And if you're slightly sick, infecting them with whatever you have. Talk about goggles, safety glasses, or face shield that actually prevents them from breathing blood or some other infectious substances onto you. And so during COVID, we saw a mix of things like at restaurants early on, they wore a mask and then a face shield. And the idea is the mask prevents them from infecting you. The face shield prevents them from infecting you. This all comes down to basic standard precautions. None of this was invented for COVID. This was all stuff that we learned as EMTs, all stuff that we learned in basic medical training. And so this applies. Now, chances are you're not going to be wearing a face shield in the field, but safety glasses are important because, and goggles are important because there's going to be dust in the air. That N95 mask is going to keep you from breathing that dust in. Those goggles are going to prevent the dust from getting in your eyes. And if you're working on a patient, those goggles, someone who's got injuries, there's going to be blood everywhere. And you don't want to get that into your eyes. You don't want to breathe that in. So you want to protect yourself from whatever's going on in the field. Closed-toed shoes. Point blank, if you're not wearing closed-toed shoes, you should not be in the field. There's hazards out there. You're going to kick something, you're going to bump up against something, something might roll onto your foot. And if you're wearing sandals, that is going to take you out of the field real fast. Long pants, you're going to brush up against stuff. Yeah, it might be hot out there, but you don't want to get injured. And long pants are going to keep whatever might scratch up your legs from doing so. I'm not a fan of alcohol sanitizing wipes. I'm sorry. I'm not a fan of hand sanitizer with alcohol. Alcohol actually dries out your skin. The professionals, EMTs, paramedics, we use BZK wipes. So they make hand sanitizing wipes out of BZK. I prefer this over alcohol. So I think the hand sanitizing wipes are better than the gel because the gel might kill the stuff on your hands, but it's still there. With the hand sanitizing wipes, you can actually wipe the stuff off your hands and really clean your hands off. But nothing beats soap and water. If you have the opportunity, you should always use soap and water. And then if you're working on a patient, change gloves between patients. Take the gloves off before you reach for supplies. You don't want to contaminate the stuff in your bag. You don't want to cross-contaminate. You don't want to infect other patients with the bad stuff that another patient has. But again, do what you can with the resources you have. If that's your only pair of gloves, that's protecting you from other people. You don't want to take off your only set of gloves and now you have nothing. When you're doing medical, it's a great idea to double glove. And the reason for this is that second glove is what you take off. The first glove protects you. The second glove is what you change each time. Now, sometimes something will prick a glove and it will go through the first layer and you'll check the second glove and there's no penetration. But you want to make sure that there really isn't any penetration. And what happens with nitrile gloves is when it penetrates catastrophically. Like the glove will tear apart and it'll be very obvious that it's failed. Latex gloves don't tend to fail as catastrophically. So that's one of the other reasons why it's preferred to use nitrile gloves over latex. But then also you have that extra layer of protection. So as you're swapping out the gloves, you can check to make sure that there's no contamination on your inner pair and then put on the outer pair again.
I got a couple more questions, Patrick.
Sure, Jose, go ahead.
Okay, so first one. Do you ever consider the untrained, non-injured people on site as possible resources if you're short of trained responders?
Absolutely. Yeah, absolutely. Okay. With the community emergency response team, we're actually trained to use convergent volunteers. If someone says, hey, I want to help, sure, absolutely. Now, in terms of team leadership, the hard rule we have is that any team needs to be led by a CERT trained member, but anyone can scribe. If someone can talk on the radio, they don't need to be CERT trained. They just need to be able to know how to use a radio. Yep. If you have an EMT that's not CERT trained, why not use them as a hands-on responder?
Next question. I saw a doctor's advice that says that if I'm wearing an N95, it'll protect me from getting COVID, not the other way around.
Yes, N95s are designed to they're respirators, so you're breathing through, and yes, they prevent the dust in the air. They prevent respiratory droplets from getting into your system.
Yeah, somebody's asking where to buy the BZK wipes.
Medical supplies. If you're in Los Angeles, SOS Survival Products sells them.
Yep.
You can get them on Amazon.
Yeah. Another one is there an appropriate response time in an immediate situation?
I don't understand the question.
Yeah. Is there an appropriate response time in an immediate situation, especially a multiple incident?
As soon as you can with the resources you have. Do what you can with the resources you have. Do the greatest good and for the greatest number in the shortest amount of time. They talk about the golden hour, platinum 10. Obviously, if someone's injured and they're bleeding out, you have a very short amount of time to stop that bleeding, especially if it's a hemorrhage or a severe bleed. If someone cuts the femoral artery, they can bleed out within a few minutes. And so if you take 10 minutes to organize yourselves while someone's squirting blood, that's 10 minutes longer than they probably had.
That's it for now.
All right. Maybe let's hold questions until the end.
Okay.
And we can take questions after. So after you make sure you're prepared, you're protecting yourself, you want to introduce yourself. Don't just walk up and start getting handsy with people. You see someone in need, you walk up and say, "Hey, my name is Patrick. I'm a member of the disaster response team. I'm medically trained. How can I help you? Or can I help you?" And chances are, if they are in pain, they need help, they're going to say, "Yes, please. This is what happened. I fell off my bike. I broke my ankle or whatever. I was cutting a tree branch and I stabbed myself with the trimmer. And hey, look at this. Is it supposed to be squirting blood like that?" Get consent. If they say, "No, don't touch me," don't. You know, if they pass out, you can assume that they want to be helped, but always introduce yourself. Don't just go up and start grabbing them. That's assault and battery. But what you're also doing is you're assessing a few things. If you introduce yourself and they're tracking you, they seem to be acknowledging your presence, you're getting an idea of their mental capacity. If you ask them, you extend your hand and you say, "I'm Patrick, I'm a member of the disaster response team. What's your name?" And they shake your hand and they tell you what their name is, you have an idea that maybe they're all there. But if they kind of stare at you and go, "Purple," something's not right. So as we triage people, that introduction helps us develop an understanding of how things are going with them. If they're screaming in pain as you approach and you're talking to them and they keep screaming in pain, you also know the priority of the injury. When you ask them questions, you want to get to know the how, what, where, and when. So if you ask them, "Hey, where's it hurt? What happened?" You're building that history. This is especially important when you hand off to professional responders. If an ambulance pulls up and you say, "Okay, this is Sam. She was trimming some tree branches when the earthquake happened, and she stabbed herself with the trimmers. She was squirting blood when we got here. We applied a tourniquet to the upper thigh. She has a history of anemia, and she did not eat this morning." That's information that is going to be helpful, especially if she passes out and now can't share that information. Also, if they answer questions, breathing. I mentioned that second hands-off responder. And when you're talking to a patient and you have a clipboard and you're writing things down, it's not good customer service. It feels like, especially if someone's in pain, you're distracted from helping them. You don't have that connection with the patient. So it's always great to have a second responder there, just standing off to the side, documenting all this information. You can periodically look up. Pulse is 65. 20, about 20 breaths a minute. It lets you stay connected with the patient. And also, especially if there's blood involved, you don't want to contaminate the clipboard and the pen. You don't want to be reaching into a bag with bloody gloves and trying to get supplies. That second rescuer, they can document, they can grab the stuff from the supplies. And then also, if you're the hands-off responder, remind, especially in a mass victim incident, remind the hands-on responder to change gloves. Even hand them the gloves. There's several ways to do assessments, and we have. I saw that somebody put in the chat. They call the convergent volunteers SUVs. I've heard that one before. Spontaneous was uninvolved. I forget what it is. I am spontaneous unaffiliated volunteers. Yeah. I hate acronyms. I really do because we use them all the time. CERT. I'm CERT trained. I'm CERT certified. Do you know what CERT means? For those that don't know what they mean, they're people don't want to acknowledge that they don't understand something. And so they may lie to you. We get in the habit of talking about CERT. We talk about these acronyms. We're talking about SUVs. Well, how many SUVs do you have? Well, if you've never heard what an SUV is, you don't know it's a spontaneous, unaffiliated volunteer. What do you think an SUV is? I think it's a vehicle. So, hey, how many SUVs do we have? Well, none. I mean, maybe we have a minivan. Oh, you're talking about volunteers. It's not. We want to communicate in plain English. And so I don't like acronyms for that reason. But there are acronyms that we use in medical. I'm an EMT. A lot of these acronyms are coming down from the EMT training down to basic first aid. Things like PENMAN, MARCH, RPM, ABC, START triage. These are acronyms that we use in the medical field because they help us remember the steps that we need to take. So when you're approaching someone who's injured, you're visually assessing them. You're trying to get your initial impression of them. You're going to use PENMAN, and I'll explain what PENMAN is next. But when you're treating someone, you're looking for immediate life threats. You're going to be using MARCH or RPM or ABC. When you're triaging, you're going to follow the START triage method in Los Angeles. There's other types of other ways to do triage in other parts of the country. When you're doing a secondary assessment, you're going to do a head-to-toe assessment. And when you treat, you're going to try and prevent infection. You're going to try and make sure that the injuries don't get worse. And you're going to continuously reassess the injuries and the patient, not the injuries necessarily, but you're going to constantly reassess the patient, the survivor, for anything that's different, anything that's changed, anything that is now life-threatening. And this is where someone who's delayed, we don't know what happened to them necessarily, why they need help, but they could get worse. They might develop a life-threatening injury that wasn't apparent at the very beginning. And so we want to reassess often and repeatedly. And you want to determine, how is this survivor leaving my care? Because if you don't have that plan, what are you doing? You're going to stay there at the medical tarps indefinitely? You want to get these people out of here. So you want to triage, you want to stabilize, you want to treat, and you want to prepare them for transport. You want to have a plan to get them out of here. What are you looking for as you approach? We use the PENMAN acronym. How many personnel do I have? Do I have personal safety? Do I have my BSI, my basic substance isolation, my gloves, my goggles, my face masks? Are there environmental hazards? Am I approaching, there's wires down, or there's this weird smell in the air? It smells like freshly mowed grass, but I don't see any lawns around here. It smells like rotten eggs. Do I smell smoke? Are there sparks coming off that light post? How many survivors, number of survivors I have? Do I have one? Do I have two? Do I have 15? That matters. Do I know how many I have? Maybe I'm walking up to a mass victim incident. I don't know how many I have yet. What's the mechanism of injury or the nature of illness? If it's trauma, it was a bus crash, chances are people rapidly decelerating and hitting something. That's the mechanism of injury. Or I walk up and I smell something funny and there's a bunch of bodies on the ground. There's no obvious signs of trauma. What caused this? Am I now at risk because I'm walking up to a hazmat situation? What additional resources do I need before I can respond adequately? Do I have supplies? If I don't even have basic nitrile gloves, am I going to get my hands bloody? If I don't have medical supplies, am I going to be able to treat injuries? If I don't have backup, am I going to be able to do any good? If I don't have a radio, am I going to be able to call for help? And do I need outside help? Do I need paramedics here? If it's one person, they fell off a bike, I might be able to bandage them up. Maybe they can go home. They just, they had a bad day. They sprained their ankle. They scraped their knee. I've got some, basic first aid kit. I've got gloves. I can take care of them, get them back on, get them home. If I'm walking up on a bus crash, and I see bones sticking out, I see squirting blood, I'm going to need some professionals there real fast, or people are going to die. So that's what you're looking for, penman. Personal and personnel safety. Or do we have what we need to stay safe? Can we do this? Are there environmental hazards that make it unsafe for us to be there? How many people do we have to treat? What are the nature of their injuries? What happened? And what help do we need from our internal? Do I need additional CERT responders? Do I need an additional team here? Do we need paramedics? Do we need fire department resources? That's what you're thinking as you approach, what you're looking for, what should be going through your head before you even get there. If you're walking up and you see it is not safe, I don't have the resources for this, I need to be calling for help. Do that. If I'm not the right person to help them, call for help. Get additional resources there before you get overwhelmed. Then, as you're working on them, what are you looking at? You're looking for life threats. As you approach somebody and you see squirting blood and they're screaming for help and they're grabbing their leg and it is like squirting through their hand or it's pooling underneath them, you need to do something real fast about this because they're going to lose consciousness, they're going to bleed out, and then they're going to die. If they're not breathing, however, you approach and you see the squirting blood and they're not even breathing, you need to make sure that they're salvageable. If you can't get their airway open, but you can stop the bleeding, well, all bleeding stops eventually. It might be the person died because there's something blocking their airways collapse. There's nothing you can do about it. You throw a couple tourniquets on there, you stop that bleeding, but they're dead. You wasted resources. So you're constantly evaluating and you're working with your partner on this. So ABCs, when you learn basic first aid, airway, breathing, circulation. Do they have a patent airway? Are they breathing? What circulatory issues are they experiencing? When you're triaging, you're looking for respiration, perfusion, mental status. These are all the same basic things. Are they breathing? Do they have circulation issues? And does that lead to a problem with their mental status? That determines the level of criticality that they have. Is this person going to die in the next hour without medical attention? That's what you're trying to figure out here. What do I need to do to stop this person from dying right now? so that we can keep them alive long enough to get them to the hospital to save their life. If they're squirting blood from a femoral bleed and you can throw a tourniquet on there and stop that bleeding, and they have an open airway and they're talking or they're screaming for help, you can slow the impending death down so that you can then get them to the hospital, or you can get them transportation to the hospital so that someone else can save their life. The last step on March is hypothermia. If you go through a traumatic injury, you lose a lot of blood, something has happened, you lost a limb for that matter, that circulation disruption is going to result in your body not being able to keep itself in homeostasis, meaning it's not able to operate correctly. And that's going to result in the environment playing a factor in this person. If you can't get them to the hospital right now, they can't self-manage their temperature. The ground that you put them on is going to suck heat away from their body. Even if the ground is 70 degrees and it's 90 degrees out, well, chances are 70-degree ground and 90-degree weather, not going to happen. But say it's 70 degrees out, and you put them on 70-degree pavement, that is going to be colder than their body. It's going to leach heat away from their body, and they can't self-regulate temperature now. So you need to separate them from the ground, and those Mylar blankets are a great option. Putting them on grass, the grass is going to be colder than their body temperature. So you have to be very much aware of where you're putting your survivors, because you don't want to actually cause them more harm than trying to save them. So putting a couple layers of insulation between them and the ground, putting a Mylar blanket on top of them to keep their body heat in is going to be critical to keeping them alive long enough for them to get the medical attention that they need. That start triage I mentioned, and this goes back to the RPM. It's how do you determine if someone needs immediate medical attention? And that's evaluating 3 basic categories. Are they breathing abnormally fast? If they're breathing twice a minute, and you know what normal breathing looks like, we breathe normally, for most of us do anyway. But if they're panting like this, they're not getting enough oxygen in. Something is wrong. The body has experienced some sort of trauma or some sort of illness, and it is not working properly. They need immediate medical attention, or they're going to die in the next hour. If you do a capillary refill in that test, and that's a perfusion check, you're going to pinch the nail bed, and you'll notice that if you say take your thumb, squeeze it for a few seconds, let go, you should notice that it goes white and then goes back to normal color within 2 seconds. If it takes longer than that, they're not getting enough blood perfusion in their extremities. Something's wrong, and they need immediate medical attention. They can't follow simple directions. If you've experienced a trauma, you have blood circulation issues, there's not enough blood getting to your brain, and you can't follow simple directions, or something seems off. You're talking to them and they can't track you correctly. They say weird things. Don't ask them their name necessarily, because you don't know what their name is. Or if you do, this is Bob and he says Sam, or you extend your hand and they kind of stare blankly at you, or off to the distance, or eyes go like that. Something's wrong. Mark them immediate, because you don't know, is this normal for them, or are they really experiencing medical emergency? It's better to be safer than sorry. But if you mark everyone immediate, that also defeats the purpose as well. And then you want to, of course, re-triage often. We'll talk about triage in a future training, and we've done it in the past. This is really a quick overview of when you're approaching a medical incident, what you want to be assessing, what you want to be looking for. You want to try and identify the people who need immediate medical attention. Where are your priorities? It's the people who are already circling the drain, and you need to try and do whatever you can to stabilize them long enough to get them to immediate, to definitive care. We talk about mental status on the AVPRU scale. If someone is alert, talking to you coherently, if someone is talking, but they're kind of not all there, you're talking to them and they kind of drift off, and you talk to them again and they kind of look up at you, but then they drift off. They're responding to voice, or if you're yelling at them, you're getting their attention, but you can't seem to keep it. Or they're not responding at all. You have to squeeze them, you have to shake them to get their attention, and then they drift off again, or if they're not responding at all. So when we talk about mental status, we say ANO times 4. They're alert and orientated to everything. Or ANO times 3. They're not quite there. You can get their attention. ANO times 2. They're only responding to pain. You don't necessarily need to know this, but if you hear that, that's what this means. So if you hear somebody on a medical TV show saying that they're ANO times 4, that means they're alert and orientated. They're fully awake. They're ANO times 2. Things are not good for that person. But that's what it means in general. If you're starting to go downhill, your alertness, your mental status is going to go downhill in that order. You're not going to be fully alert. You're going to start drifting off, and only certain things are going to bring you back, and probably not for that long. Oh, I'm sorry. I made an error on the ANO times 4. So ANO times 4 is alert to time, person, place, and event. So they know they know what time it is, they know their name, they know where they are, they know what happened. If they're ANO times 3, they missed one of those 4. ANO times 2. When you're approaching a trauma, you're looking for certain things. The acronym for this is DCAP BTLS, or DCAP bottles. And you're looking for deformities. Yeah, that leg should be straight and not have a 90-degree turn in it. Contusions is there bruising? Abrasions, looks like they got scraped. They maybe have road rash. Maybe there's some debris in it, like there's gravel in the scrape. Are there punctures or penetrations? Did something from the outside go into the body that shouldn't be in there? Burns. They touched something hot, flames, whatever. Superficial is a 1st-degree burn. Partial thickness is a 2nd-degree burn. Full thickness is 3rd-degree burn. There's also a 4th-degree burn where it actually burns down to the bone. Tenderness. If you touch somebody, you're assessing them and they recoil from that touch. That's tenderness. Lacerations or cuts. The cuts can be either clean or jagged. You also want to note the depth of the cut. Did it go in deep, and how long is it? Because that's going to impact how we can treat them. If they have a small cut, it's easy enough with a Band-Aid. A little bit longer cut, maybe we can use butterfly bandages on them. Anything longer than that, we need stitches. They need to go to the hospital. Swelling. You get a bump and it starts to swell. Generally not a good thing, but it's the body's reaction to it. And the bigger the bump, the bigger the swelling, can actually cause problems with clothing or jewelry. If somebody has a ring on their finger and their hand got injured, their hand is going to start to swell. You want to get that ring off before it actually cuts circulation to that finger. Clothing, they're wearing tight clothing and they're starting to swell. You might want to loosen the clothing before it actually starts to impede their blood circulation. When you're looking at the body, we generally have symmetrical bodies in terms of there's one of everything down the center and there's two of everything out to the extremities. So you have one nose, one mouth, one heart. You have two eyes, two ears, two arms, two hands, 2 feet, 2 legs. When you're talking about the anatomical possessions of the body, you're referring to them as if they're standing upright and from their perspective. So their left, their right. Proximal is to the heart, distal is away from the heart. Medial is to the center of their body, lateral is to the outside. This is all just, it's stuff that you hear people talking about when they're professionals. I don't recommend you using these words unless you are really comfortable with them and you know what they are for sure. I'm providing this as examples of stuff, but this is not an EMT course. This is just very basic anatomy. So it's stuff you should be aware of. And as you continue on with your community emergency response team training, as you get more advanced medical knowledge, this stuff will make a lot more sense. But if there's only one and there should be two, you should probably take note of that. If something is shorter on one side than on the other, you should probably take note of that. And if they're conscious and you can ask them questions, maybe that is their normal. Ask them, hey, is your left leg is shorter than your right leg. Is this normal? No, it's not. Okay, something's wrong here. We need to address this, or at least need to be aware of it. Because if they landed wrong and now you have a break in the leg, it's extremely possible that one leg is shorter than the other because the bone is broken and now it's sliding next to each other. And that's something you want to take note of. Now, they might say it's normal. Then, okay, cool. We noted it and it's normal. So the next person who assesses goes, oh, it says here that one leg is shorter than the other. Okay, don't have to worry about that. What'll happen is if you have a mass victim incident, you're going to be setting up a medical treatment area. If you have multiple injuries coming in, you have to transport to a central location where you can treat them all. You want to set up that treatment area close to the staging area so you can get more resources to them, or close to the site of the incident so that you don't have to transport people away from that incident over a great distance. And where you set up the treatment area is really going to depend on the situation. If you have injuries coming from all over the place, set it up close to staging. If you have injuries at one location from that one incident, set it up close to that one incident. We're going to follow the same staffing protocols that we've been talking about, where we have a team leader or a treatment group supervisor, a scribe, and a radio communicator. This is all the same format that we've been following. So you don't have to come up with this over and reinvent the wheel each time. The treatment area is going to have generally three colored tarps. There might be a fourth tarp. You know, a red tarp, a yellow tarp. You may have a green tarp. Don't necessarily need a green tarp, but it might be there. If you're possibly going to have people who are going to die on your tarps, you might want to have a black tarp. You're going to want to move the people who have died. And unfortunately, during a disaster, people will die. You can move them away from the other injured people because, well, if you're already having a really bad day and you're looking over and you see somebody who's, you're going to have a worse day and you're going to be freaking out a whole lot more because that person was just talking to me a few minutes ago and I think they're dead. get them away, move them, don't make a big scene about it. Unfortunately, you will have people, they're circling the drain already. We can't get an ambulance here fast enough. Chances are they're going to die. What are we going to do about it? The treatment group supervisor and their scribe are going to be tracking, and this is important. This is why the scribes are so critical here. You need to track all incoming. You want to track all outgoing. You want to track the retriages. You want to make sure you have good flow of information and you know how many survivors you have on the tarps at any given time and a priority that you need to get them out of there. So the way I set things up is I have got the 3 tarps set up, the immediate, delayed. Maybe there's a green tarp over here, but I want to, if I'm the treatment group supervisor, I want to be here in the center, and have all the incoming come through me. I'm the initial point of triage. I don't want people coming in from multiple directions to these tarps and just leaving bodies on the tarp without any accountability. Everything needs to come through me. So if you can back your tarps up against a fence, so there's only one way in and out, that's ideal. Especially in chaos, tracking your incoming is going to be critical. And so I've seen it where it was utter chaos. You had teams coming in left and right, back and front, and they're just dropping people off and there's no accountability. So everything comes through the treatment group supervisor. It gets initially triaged. The scribe documents, okay, you're immediate, you're delayed, you're immediate, you're delayed. Why are you even here? Go over there. Scribe is documenting, and then they get to the tarp leader. The tarp leader is going to re-triage again. Okay, yeah, you're immediate. You're definitely immediate. I need you to lay down here, or I need you to put them down here. And their scribe is also there to document as well, so that there's the numbers need to add up. If you've got if you've documented 5 people on the red tarp, then the treatment group supervisor's scribe should also have 5 people on the red tarp. What happens if one of you has a different number? What just happened? Did I lose somebody? Did we misappropriate? Did somebody get up and walk away? Did somebody, get transferred? You need to have those numbers matching. So the treatment group supervisor is the overall, they're in charge of all the tarps. They're tracking the incoming, they reassess, and then assign the tarp that survivor is going to go to. Their scribe is going to be tracking the outgoing and incoming, any status changes. That communicator is the one who's going to be communicating with staging, letting staging know, yeah, we've got 15 on the red tarp. We need fire department to transport, or we need some way to get these people to the hospital. We now have 14 on the red tarp. We're moving 1 to the black tarp. The tarp leader and their scribe, they don't need a radio communicator there because they're going to be in close proximity. The scribes are going to be able to talk to each other and confer notes. They're going to see, they're just in charge of their tarp, versus the treatment group supervisor really has that overall picture. They need to make sure that they know everything that's going on. But they're not being detail oriented. They just need to know numbers and make sure that the flow is going smoothly. The red tarp leader, the yellow tarp leader, they're detail oriented. They're making sure they know. They're saying, hey, no one looked at this guy in 15 minutes. I need somebody to reassess them. And then you're working with the teams, the hands-on responders on the tarps themselves. And as a tarp leader, you're making sure that everyone's getting assessed and you've got guidance going to your people. Hey, I need you to look over there. Hey, that person's looking really pale over there. I need you to go check on them now. Make sure that they're still doing okay and they're not getting worse. And treatment group supervisor, we're on the delayed tarp. That person who got really pale, we need to transport them over to the red tarp now. They're not doing good. And then each of your scribes are going to update their notes accordingly. And then hopefully as people get taken out, transported to definitive care, it's going out through the treatment group supervisor as well. And the treatment group supervisor is going to refer to the TARP leader and say, okay, who do you need to transport now? We have an RA that can take 3 people. When you reassess, you should be reassessing everybody at least every 15 minutes. If they're not stable, they're in bad shape, you're going to reassess them every 5 minutes. Now, this is really hard when you have 15 survivors on the TARPs and there's 2 of you. But it is the goal to reassess everybody every 5 minutes if they're unstable. Once they get to the TARP, you want to do a detailed assessment, a head to toe. You want to make sure you know what's going on with this person. Maybe they came in with a head trauma, but as you do the head to toe, you realize, hey, there's a piece of rebar sticking out of their back that got missed. If we're laying them on their back and it's penetrating into the body, it's going to actually make things worse for this person. And again, if you have the resources, one person hands-on, one person hands-off scribing, handing medical supplies to the hands-on responder is ideal. Not necessarily achievable, but ideal. Typical things you're going to be doing at the TARP. These are called interventions, treatments. When you set people up, you want to set them up head to toe, head to toe, head to toe. That way, as you're moving down the line, you're able to really operate efficiently. For one particular reason is actually people will vomit. People will throw up, especially if they've been in trauma, if they've had food in their system. Things will go south. You don't want 2 people head to head and one person throws up and the second person is going to throw up as well. And there's that visceral response to people vomiting. So you want to make sure that you have some sort of distance. Also, if they're coughing, spitting up blood, if you have them head to head, they're going to be getting each other cross-contaminated. So set them up head to toe, head to toe, head to toe. Try and have it organized so that your responders can move one person to the next person and the next person in a seamless fashion. Just don't throw them ad hoc, left and right, and X's and diagonals on all over the place. Try and keep some order. It's going to help manage the chaos by having them in an orderly fashion. That also means you probably want to start putting people maybe not in the center of the TARP, but off on the side in a row, and start putting people into a row from the very beginning. I think the common thing is we have a big giant TARP, a 20 by 20 TARP. We're going to put someone in the center, and we're going to put someone next, a good distance away from them, so they're not on top of each other. But if you have 20 survivors on the TARP, that gets disorganized really fast, and then you have to reorganize. So if you start on the corner with survivor number 1, and then survivor number 2 at their feet, survivor number 3 at that person's feet, you start off having it organized from the very beginning. Bleeding, you're going to have people bleeding. You're going to apply direct pressure. If you have pressure bandages or tourniquets and that direct pressure can't stop the bleeding, then you're going to do something a little more to stop that bleeding. Sprains, strains, dislocations, fractures. There's not too much we can do about this, especially at our medical level. Even as an EMT, you're pretty much going to splint in place. You're going to try and make sure that whatever's going on with this joint or dislocation, it doesn't get worse. And if you're splinting, you want to make sure before and after you check for color, motor function, temperature, sensation. Make sure that they can feel, that there's color in the skin, that it feels warm to the touch. And after you splint in place and they can feel it, after you splint that injury, that it's not cool, they can't feel it, they can't move it, You have to loosen the splint if that's the case. Or if they already have some sort of degradation in their CMTS, that you note that beforehand and it's not getting worse. Open fractures, open injuries, you want to cover them with sterile dressings. Prevent the bad stuff from outside getting into the wound. Shock, you're going to treat, lie them flat, keep them warm, raise the feet, try and keep blood circulating towards the head. And then you want to make sure that people maintain an open airway, patent airway. And if you need to, especially if you have limited resources, you want to make sure that you put people in the recovery position. And this is going to help them keep their airway open by lying them so that their arm will actually keep their airway open. And if they throw up, they vomit, that it will clear and not get stuck. If you're lying back and you throw up and you're unconscious, you will aspirate, you will choke on your own vomit. So again, this is not a medical class, but this is why you'll see people lying on their side like this with their hand under their head and their knee up like that. That's called the recovery position. And then when you have definitive care approaching, you have EMS, you want to give the patient name. So you try and get as much information as you can. I've heard people taking cloth tape and putting them down the pant leg or the arm and writing information on that. CERT doesn't really have a good way of tracking per patient information, but that's one way to do it. Patient name, age, sex, what time they arrived, their chief complaint, any treatments that you did, any interventions you did. And then let staging know that you've handed off to EMS and they've been transported, who took them and where are they going. That should be documented in your notes, especially if you're the TARP supervisor. That was a lot of information. The incident is not something that's going to be quick. If you're in an earthquake, the incident will go on for hours, days, possibly weeks. It's a marathon, not a sprint. But what we do helping our neighbors, especially in the first several hours, if you have things under control, chances are the fire department's going to look at you and go, these people have their stuff together. These people know what they're doing. We're going to focus on where we need to help people more. And that organized neighborhood is going to be able to keep things going. They'll let us know when we need to come help them. And that's a good thing. It might not be great when you see fire department show up and you tell them what's going on. They go, you got this. And they drive off and you thought they were coming to take over. But they realize that you've got control of the situation and there's other parts of the city that does not. We do these trainings to bring you up to speed. We do these trainings to give you an idea of where things need to go for the operation. And then we do drills to help you really test your skills and learn more. And we encourage you to take additional training. Take first aid, CPR, AED, take emergency medical responder if it's offered, take EMT classes. People are going to get hurt. People are going to get injured. What we do in the first 3 hours will save lives. In October, I think it's October 26th, we have a triage drill that we're going to be doing in the West LA area. I'm going to put up the Eventbrite shortly. This is where you're going to get to do triage over and over again. We're going to start doing our medical drills that we were doing pre-pandemic again. So that's the triage drill, that's the treatment at the TARP drill, where you get to do the skills over and over again, reinforce them, learn, make mistakes there, but figure out, the flow of things, how things should look in ideal circumstances so that you know where you need to get to, even if you have very few resources. Our trainings are up at our YouTube channel. If you search for LAFD CERT coordinators or LAFD CERT continuing education, you'll find us. Our trainings are up on our calendar, calendar.ntp-la.org. And if you haven't yet signed up at our email list, join.ntp-la.org. If you need to reach out to me, you can find me at lafdcertcentral@gmail.com. You can also find the LAFD Cert website at www.cert-la.com. All right. So, like I said, that was a lot of information.
There's a couple questions. Okay, Cynthia Chambers mentioned something about getting back on the radio system because she's outside of LA. I asked her if that meant Zello, but she never responded. Cynthia, are you out there?
Yes.
Email.
Okay. Yes, I'm talking about Zello.
Zello, okay. So you don't have a Zello user outside LA, you're in LA County now. You,
Yeah, I'm in Palmdale.
Palmdale, okay. So do you want to take this, Patrick?
Yeah, just email me at lafdcertcentral@gmail.com, and I can help you out with that. I put my
Yeah.
email in the chat.
Can you put that in the chat, please?
I already did. If you don't
Thank
see it,
Okay, the next one is from Jan Northrop. What is the effective number of people a TARP leader and scribe can keep track of?
Incident Command System talks about span of control, and that is we can track up to 7 people, 3 to 5 being optimal. Those are your direct reports. So if you have more than that many people, it becomes more and more difficult to really control's the wrong word, but really to supervise or direct them.
Yep.
If that's the case, you need to break that up, and so that's the system that we have in place. That's why the TARP supervisor is not directly overseeing the TARPs. They have a TARP leader in place at each of the TARPs. Now, initially, you might get there and you're the only one there and you're doing everything, but you want to quickly delegate as quickly, or you want to delegate as quickly as possible. And maybe the TARP leaders are the people who are hands-on initially, but then as more responders show up, that's when they start to delegate as well.
Okay, next one, Jeff Romaine says, will we get something showing that was done? This was done so we can give it to our CERT coordinators. I don't think you need to give anything to your CERT coordinator.
No, this is informational. If you get a first aid certificate, there's a certifying agency issuing those. We're not issuing certificates of completion, at least not now.
Jan Northrop has, do you have a list of best places to get emergency medical training? Red Cross, I mean, they have all sorts of classes.
Yeah. Red Cross, American Heart Association.
Yep.
You just go on their websites, you can search for classes.
Okay. A lot of thank yous.
You're welcome.
Oh, wait a minute. I offer free first aid, CPR, AED, Brian Brown. Brian, if you, are you certified trainer, Brian?
I would
out
still
there,
recommend going through the websites.
Yep.
That's the easiest way, because we do have people who from all over the country on
Yep.
on this training.
What items would you suggest for a go kit in addition to forms and first aid items? Boy.
That's a different class entirely, different training entirely.
Yeah, that's a different thing to go. I mean, there's different kind of go kits too. Yeah, I would go to ready.gov, and you got different types of kits in that. Ready.gov is the best place to go. Oh, right, cool. Brian Brown is actually an instructor for Red Cross. Cool. Brian, where are you located? Yep.
All right. Any other questions, Jose?
No, that's it.
All right. If you have any questions you want to ask them, go ahead and raise your hand and can answer them. This training is being live streamed onto our YouTube channel. So if you want to rewatch it, or if you missed the first part, or share it with your friends, share it with your colleagues, share it with your team members, please do. It'll be up under the live section, and then if we get it, it'll get reposted on the main section.
Phyllis Chin has a question. Has her hand up.
Yeah, so turn this off there. You suggested as part of your assessment offering to shake hands, but if you've got a sterile glove on, that seems counterproductive. Do you want to talk about that?
Yeah, that's a good point. If their hands are bloody, maybe don't. The sterile glove is again to protect you from them. But obviously it's kind of an indication you're trying to assess their mental status. Some cultural and religious differences may also make it that they don't respond to that. So it's not necessarily if they don't shake your hand that is an issue. If they do shake your hand, you know that things are going correctly. At least you have an idea that things are going correctly. But if your hands are bloody, you haven't changed gloves, don't shake their hand. Don't offer to shake their hand. If your gloves are clean, then you can offer to shake their hand. That makes sense. Steve. Steve, go
You're
ahead and
muted,
unmute
Steve.
yourself. Steve, go ahead and unmute yourself. There you go.
Sorry, I thought I did that. Great mouse. If the span of control is 7, could that be 7 teams controlling just your team leader?
Yes. 7. So your direct reports. So you would have the team leader reporting to you directly. And they might have a team of 7 and a team of 7 and a team of 7.
Yeah. Okay.
Any other questions? Like I said, there was a lot of information we threw at you. A lot of these, we want to give you the overview of a very broad subject. The drills that we do are designed to get you in the field so that you can actually experience being on an incident response team. And we give you over to a facilitator who tells you a story, and you as a team work together. But you need to have the kind of the big picture of how all this works together. And we only have, an hour and a half to go over the subject. And we could do an entire training on just the medical TARPs or just patient assessment. So we kind of threw a lot of information there. So I understand if you do have questions that you come up with later, feel free to email me. We'll rewatch the video. If you come up with questions after the fact.
I made the teriyaki chicken.
Oh, okay.
And I warmed up the stir fry.
Sounds like someone's ordering dinner. So we do these continuing education trainings monthly, every third Wednesday of the month. In September, I don't know what we're going to be doing. I do want to disclose that Eventbrite is changing how they're doing things. Starting September 6th, Eventbrite will start charging for events with more than 25 tickets. I don't think we're going to continue using Eventbrite. I don't know what other options we have. We are exploring options right now. We're looking at getting our team organization system developed. And that will include a event management system. But we're probably not going to be using Eventbrite necessarily in October for sure, maybe not even September. But we'll let you know through the email list what we're going to be doing, how things are going to be changing. But I do want to thank everybody for attending tonight. A lot of you stayed throughout the entire session, so I really appreciate you. Hopefully you learned a lot. Hopefully you have a little bit better understanding of how things should flow and how you can help your neighbors out. Roxanne.
Roxanne, unmute yourself.
Sorry about that. Hi, about your email list, I'm in Northern California, in the San Jose area, and your class is phenomenal, and I'd like to continue with your the continuing education. Can I just put my email address in the chat and get on your email list, or is this just for the LA? Well, obviously it's not just for the LA area because I'm on this call.
So we opened up the NTP-LA list to non California, non-LA residents. I would prefer that you sign up through the join.ntp-la.org, just because it's easier for me to add people. I'm not going to add. I'll be quite frank. If you put your email in the chat, I'm not going to add you. So please sign up through that. certvolunteer.org is the same list as well. And we're working on developing that as potentially a nationwide system.
Ivan's got a question.
I just want to say hello, thank you. And as a fellow CSG member, that I'll be adding this to my Form 20s. It's my Form 20. Can you hear me?
Yeah, we can hear you, Ivan.
Oh, okay. I was like, oh, I didn't know if you guys could hear me or not.
Yeah.
All right, have a good day. Thank you.
Thank you. All right. Well, if there's no other questions, then we'll give you back 15 minutes of your day. Again, thank you so much for coming out, and hope to see you back next month.
I have one question.
Yeah, go ahead.
How do you get the colored tarps?
They do sell them online on Amazon. They sell them at SOS Survival Products. You can find them.
All right, thank you.
You're welcome. All right.
Good
Have a good night,
night.
everyone.
Good night, everyone.
Lancaster says thank you.
Thank you, Lancaster.